We're going to use this puberty lecture to introduce concepts of the hypothalamic pituitary axis, talk a lot about precocious puberty, and then introduce some concepts of delayed puberty, recognizing we're going to go through the details of those diseases in the primary amenorrhea lecture. Let's start off by talking about precocious puberty and giving us an idea of puberty in general. You will not have to memorize Tanner stages for red bud development and axillary hair and stuff like that. You don't have to commit that to memory unless you're going to be a pediatrician. But what I do want you to know is the natural progression of a girl going through puberty. It is fairly reliable and occurs in the same order in all patients and has a relative age that makes it normal. A girl is going to go through the development of her breasts, then axillary hair, then a growth spurt, then menarche. And this can reliably happen at 8 for breasts, 9 for axillary, 10 for growth, and 11 for menarche. Now, in reality, we know that puberty is occurring in younger and younger ages. 7 is now considered the earliest, and even 6 in African American girls. But for the test, you should use the traditional age of 8, 9, 10, 11. And it's important to recognize that growth spurt happens before menarche. Precocious puberty that's happening too early isn't a big deal unless she gets ahead of herself and the growth spurt ends, menarche happens, and she's a shorter stature than she normally should be. Or she has some deficiencies of her bones because her bone age is greater than her chronological age. The way I remember this was taught to me by an obstetrician. It's going to be tits, pits, mitts, and lips. That is breast development, axillary hair development, growth of long bones, of which the mittens would go on their hands, and lips to remind her that's where she bleeds from. The idea behind this is that as she goes up to menarche, the levels of progesterone and estrogen are effectively negative. But as she approaches bleeding, estrogen levels spike, they reach a certain threshold, and she bleeds. The idea is to intervene on precocious puberty to allow for normal bone development prior to menarche, which would then end her growth spurt. Okay, so to get into this, what I want to talk about is the hypothalamic pituitary axis. The hypothalamus influences the anterior pituitary, which then tells the ovary to tell the endometrium to proliferate and eventually bleed. Now, also influencing this system are going to be the adrenal glands, because the adrenal glands can make androgens. The end product is an endometrium that bleeds. The physiology here is the hypothalamus secretes GnRH in a pulsatile fashion to the anterior pituitary, which stimulates FSH and LH to be released. That stimulates the ovary to make estrogen as well as progesterone, but it's the estrogen that causes proliferation of the endometrium. Androgens can induce endometrial development, and the adrenal glands can make DHEAS, and the ovaries and adrenal glands can make testosterone in the way of tumors. These will also influence endometrial development. So the things that can go wrong here at the level of the hypothalamus, there's not really going to be any tumors, so this is essentially going to be constitutional. The level of the anterior pituitary, there can be a tumor that secretes FSH and LH, but that's exceedingly rare. Usually tumors of the anterior pituitary turn off the axis rather than stimulate. The ovaries where a lot of the issues can happen. You might have a cyst or tumors of the germ cells, like granulosa theca, which is going to produce estrogen, or a Sertoli-Leydig, which is going to produce testosterone. At the level of the adrenal gland, you can have congenital adrenal hyperplasia or a tumor that is secreting exogenous androgens. Any of these things can lead to an overstimulation of the endometrium, which leads to bleeding. So the idea here is, how do we work up this axis? When someone comes in with secondary sex characteristics, and is less than 8 years old, this is someone you should consider for being worked up. The first thing you want to do is determine their bone age, and you do that by looking at a wrist x-ray. This is positive and pathologic if the wrist x-ray shows a bone age that is 2 years greater than their chronological age. For the sake of this discussion, let's just say it's positive, because if it's negative, you don't need to consider this any further. If you have precocious puberty, because the bone age is 2 years greater than the chronologic age, then you need to find out where is the stimulation of the axis coming from. Is it from the central nervous system, that is the anterior pituitary, or is it not from there? To do that, you use a GnRH stim test, also called a leuprolide stim test, because leuprolide is effectively GnRH. If this stimulates LH, then you know the axis is active and it's a central condition. If it's a central condition, you want to look at the brain. The best way to assess the brain is an MRI, especially in a child. You don't want to expose her to radiation. If the MRI is positive for a tumor, great, you resect it. But if you've definitively diagnosed this as a central lesion and there is no tumor, that means it's simply constitutional, which is fine, except that you want to treat her to allow her chronologic age to catch up to her bone age. The way you can do that is with continuous leuprolide. GnRH is stimulated in a pulsatile fashion that stimulates FSH and LH. Continuous GnRH turns off the axis. So giving leuprolide, which is GnRH, continuously turns off the axis and allows her body to catch up. If that stim test failed to change the LH, now you've got a peripheral lesion. And peripheral lesions can be in the ovary, adrenal gland, or anywhere else. So you have to go fishing. And unless they give you a really strong clue, you're basically going to do all these things at once. You're going to get an ultrasound of the abdomen, which is essentially looking for an ultrasound of the adrenal glands. You get a transvaginal ultrasound to look at the ovaries. And you want to test for levels of DHEAS and testosterone. If you're considering it, get 17-hydroxyprogesterone in the urine to consider congenital adrenal hyperplasia. And what you're going to get is one of three things. You're either going to get congenital adrenal hyperplasia, and the way you treat that is with steroids. We're going to talk more about this in the virilization lecture, but effectively, because of a 21-alpha-hydroxylase deficiency, you can't make glucocorticoids, cortisol, or mineralocorticoids aldosterone. So the adrenal gland, recognizing it's not making enough, attempts to make more, but it shunts all of that cholesterol into making androgens instead. If you give the glucocorticoids and mineralocorticoids that the girl needs, the adrenal hyperplasia will turn itself off. If you find a tumor, and it doesn't matter where it is, you are going to resect. And the only time, if you find a cyst, this is the only time you might use reassurance. All right, that's precocious puberty. A little bit of physiology, and then how we determine what to do next. The idea is determine a bone age, GnRH stim test, and then use some sort of imaging and biochemical markers to help find out where the problem is coming from, and then fix it. We're not going to spend that long on delayed puberty. And that's because a lot of these diseases that we would cover here are covered in primary amenorrhea. But if you have no sex characteristics by 13, or you have no bleeding by 15, give consideration to delayed puberty. If you have this condition, you want to do a bone age, the wrist x-ray, as well as a biochemical profile, FSH and LH. What you want to do is separate into hypergonadotropic and hypogonadotropic hypogonadism. If the FSH and LH are elevated, the axis is turned on, and there's just nothing receiving the signal. This is hypergonadotropic hypogonadism. The axis is on, the ovaries aren't responding. These are going to be conditions that are typically karyotype diagnosed, and the fact that they either have no ovaries or their ovaries are failing to respond to the signal. Generally, you do a karyotype. We'll talk more about these in primary amenorrhea. If the FSH and LH are not elevated, and the axis has not been turned on, and you've got hypogonadotropic hypogonadism. In here, you're looking for the cause of why the axis hasn't turned on yet. And again, you go fishing. You're going to get a prolactin level for a prolactinoma, a TSH and a free T4 for thyroid disease. If what you care about is bleeding, you'll get a pregnancy test. And then you're going to look for chronic diseases like CBC, LFT, and ESR. And ultimately, you'll do an MRI to rule out pituitary lesion. Now, if you have one of these things, awesome. It's positive, you find out what the disease is, and you treat it. Again, primary amenorrhea lecture where you're going to learn about those. What I really want to sell here is constitutional delay. That is, if everything's negative, it's constitutional. Two things will come up for constitutional delay. First, the right answer is just to wait. It is okay, it's taking this long. They've got normal anatomy and a normal axis. It just hasn't turned on yet, which means you do not do growth hormone. Patients or their parents may want them because their kids are small or they haven't developed yet, so they're trying to get you to give them something. If it's constitutional delay, don't do it. And you can forego all this testing if you've got a family history. If mom didn't start puberty until 16 and her daughter's 15 and still hasn't started, it may be that she just hasn't caught up. So that family history can help you a lot. To review, we talked about some of the physiology of puberty in general, how to work up precocious puberty, bone age, GnRH stim test, and then some sort of imaging, and touched on briefly the delayed puberty, recognizing that a lot of the diseases we're going to talk about in the primary amenorrhea lecture come up in the next lecture, but pay particular attention to constitutional delay in that it's totally normal and the kid should just wait. That is puberty.